Assalamu alaikum and good day to Miss Frafida and everyone. My name is Nurse Yafika Isa binti Che Razahali. Today, I will present an image evaluation of a lateral wrist radiograph under the supervision of Miss Rafida binti Super. This presentation consists of 4 sections. First, the radiographic anatomy. Second, the positioning criteria. Third, the exposure factor criteria. Finally, the image evaluation using the Paceman method. Let us begin with the radiographic anatomy demonstrated on a lateral wrist radiograph. The image should clearly show the distal forearm, carpal bones, and metacarpals. This image demonstrates the distal end of the radius and distal end of the ulna. Next is the carpals bone highlights the scaphoid bone. First is proximal row of carpal bone will demonstrate scaphoid, pisiform, lunate, trichotrium. Next is the distal row of carpal bone shows the trapezium, trapezoid, hamate, capitate. Lastly, the anatomy of lateral wrist is demonstrate the metacarpals, which is the base of first metacarpal is visible, and second to fifth metacarpal are superimposed. Next, I will discuss the positioning criteria for a lateral wrist projection. These criteria are used to evaluate whether the radiograph has been positioned correctly and is suitable for diagnostic interpretation. Several anatomical landmarks and image characteristics will be assessed to confirm a true lateral wrist position. The first positioning criterion for a true lateral wrist projection is the superimposition of the distal radius and ulna. As shown in this radiograph, the distal radius and ulna are closely superimposed, indicating minimal rotation of the wrist. This confirms that the wrist has been positioned correctly in a true lateral position. The second positioning criterion is the alignment of the anterior aspect of the distal scaphoid and pisiform. As shown in this radiograph, the scaphoid and pisiform are aligned, indicating correct wrist rotation. This alignment confirms that the wrist is positioned in a true lateral projection. The third positioning criterion is the demonstration of the pronator fat stripe. In this radiograph, the pronator fat stripe can be clearly visualized adjacent to the distal radius. Its visibility indicates proper positioning and adequate image quality for evaluation. The final positioning criterion is the alignment of the thumb with the forearm. In this radiograph, the thumb is positioned parallel to the forearm, indicating correct hand and wrist positioning. This helps maintain a true lateral wrist projection and minimizes rotational distortion. This section focuses on positioning evaluation for the lateral wrist projection. This radiograph evaluates rotation by observing the superimposition of the distal radius and ulna. In external rotation, the ulna appears anterior to the radius. In internal rotation, the ulna appears posterior to the radius. To improve, rotate the wrist, externally, until radius and ulna are superimposed. This slide evaluates rotation using the alignment between the distal scaphoid and pisiform. In external rotation, the scaphoid appears posterior to the pisiform. In internal rotation, the scaphoid appears anterior to the pisiform. Their relationship helps determine whether the wrist is positioned in a true lateral projection. To improve, rotate the wrist, externally, until the scaphoid and pisiform are aligned in a true lateral position. This image demonstrates radial deviation of the wrist. The distal scaphoid is positioned proximal to the pisiform, and the proximal forearm appears higher than the distal forearm. To correct this error, the long axis of the third metacarpal and mid-forearm should be aligned parallel to the image receptor. This image demonstrates ulnar deviation of the wrist. The distal scaphoid is positioned distal to the pisiform, and the proximal forearm appears lower than the distal forearm. Proper positioning can be achieved by aligning the third metacarpal and mid-forearm parallel to the image receptor. This slide evaluates thumb and first metacarpal positioning. Incorrect positioning may cause foreshortening of the first metacarpal and superimposition over the trapezium. To improve the image, the thumb should be depressed until it is at the same horizontal level as the second metacarpal. Next, I will discuss the exposure factors for the lateral wrist projection. Exposure factor evaluation is important to ensure adequate image contrast and density, allowing both thin and thick anatomical structures to be visualized clearly. This image demonstrates an optimally exposed lateral wrist radiograph. The border cortical outline of the pisiform, pronator fat stripe, and distal radius are clearly visible. In addition, the bony trabecular pattern of both the pisiform and distal radius can be identified, indicating appropriate KVP and mask selection. This radiograph demonstrates excessive KVP. The border cortical outline of the pisiform, pronator fat stripe, and distal radius are poorly visualized due to reduced image contrast. However, the trabecular pattern of the distal radius remains visible. To improve image quality, the KVP should be reduced by approximately 15% while maintaining the same mass. This image demonstrates excessive exposure caused by both high KVP and high mass. The cortical outlines and trabecular patterns are not adequately visualized, resulting in loss of image detail. To correct this, the KVP should be decreased by 15% and the mass should be reduced by 50%. For image evaluation, I will use the Paceman criteria. Paceman stands for projection and positioning, alignment, collimation, exposure, marker, aesthetic, and name. These criteria help ensure that the radiograph is a diagnostic quality and suitable for interpretation. First, we evaluate the projection. This image demonstrates a lateral wrist projection because the distal radius and ulna are superimposed, the distal scaphoid and pisiform are aligned, and the ulnar styloid process is seen in profile. The anatomy included extends from the proximal half of the metacarpals to the distal third of the radius and ulna. This position for this projection is incorrect because the anterior aspect of distal scaphoid is visualized posterior to the anterior aspect of the pisiform, indicate the patient's wrist was internally. And the ulna was positioned posterior to the radius, this indicate the patient's wrist was internally rotated. To improve, externally rotate the wrist until the wrist is in a true lateral position. Next is, the lateral wrist is deviated to ulna. This is because distal aspect of a distal scaphoid are positioned distal to the distal aspect of pisiform. To improve, align the long axis of the third metacarpal and the mid-forearm parallel to image receptor, IR. Now we moving to the alignment. In this radiograph, the alignment cannot be determined. This is because there is no evidence of foreborder of collimation. The centering point also cannot be determined, because there is no evidence of foreborder collimation. The standard centering point for this projection is direct to midcarpal. Now is collimation. Collimation should be done to all four border of film. The superior border, one half of the proximal metacarpal, lateral border is lateral soft tissue of wrist, and inferior border must include 1/3 of the distal forearm. This slide summarizes the exposure factor evaluation. The KVP used in this radiograph is appropriate. This is because the bony cortical outline of the thin structure, pisiform, can be seen on the radiograph. The bony cortical outline of the thick structure, distal end of radius, also can be seen on the radiograph. The mass used is adequate. This is because the bony trabeculae pattern of the thin structure, pisiform, can be seen on the radiograph. The bony trabeculae pattern of the thick structure, distal end of radius, also can be seen on the radiograph. There is evidence of left post-processing marker shown on the radiograph. It is correctly placed at the left side of patient's body. It is appropriately placed without superimposed with region of interest. For the aesthetic value, the film used is 18 by 24 cm, which is sufficient to demonstrate all structure of interest. There is no evidence of artifact seen on the radiograph. The last one is name, patient's identification, patient's name, place of examination and radiographer's name are not visualized on the radiograph. To improve, they should be clearly visualized on the radiograph at the appropriate area without superimposed with structure of interest. For the conclusion, the radiograph is unacceptable and requires a repeat due to incorrect positioning, absence of anatomical marker, absence of patient identification. This is all my REFENCES. THANKYOU for your attention.